as well. So just for everyone's information, tonight's webinar is being recorded. So if you have any objections, do let us know, but feel free to watch it back, or if you know somebody isn't able to join, please do let them know, and it will be on our website as usual with the other open house surgeries as well. Just in terms of introductions, my name's Rajshri. I'm your Chief Officer for Community Pharmacy Leicester and Rutland. Hopefully all our pharmacists and contractors know me by now. So I'm going to make a start, if that's okay, and I'm hoping that you'll be able to do the next slide as well. So just a couple of reminders. We do have a number of communication channels for all our contractors, community pharmacies, and their teams to access, not just in terms of social media, but we also have a very proactive and active WhatsApp group and several WhatsApp groups, including one for community pharmacy contractors, but also a locum WhatsApp group as well. So if you do want to join any of them, please do let us know. You can either email me using that email address, or just send me a quick message on my mobile as well. And again, these slides will be shared via our website as well. So moving on to the agenda for tonight, I'm going to spend the next couple of minutes just giving you a brief overview of some of the most important things I felt really quickly to inform community pharmacists tonight. So I'm going to give you a quick LLR update, and it is a very brief update, bearing in mind that I know there's a lot of activity happening have been happening over the summer period as well. Really delighted that we've got James Stevens, so I'm going to give James the opportunity just to introduce himself. I'm sure some of you already recognise him as well, but he's our Control Drugs Liaison Officer for the region as well. So James has been visiting a number of pharmacies across the patch as well. And then I'm going to hand over to Dr. Ashman, who's going to be talking about the ptosis, whooping cough. And those slides again will also be shared via our website once we've uploaded the recording as well. So let's have a look. So first thing I really wanted to share with you is just provide a gentle reminder that we do have our annual general meeting coming up, and that it feels like a very long way away, but actually it's just around the corner. So it's on the 24th of September, and this year it will be an online event, but it's not a face-to-face event. Our theme is survival instinct, and I'm absolutely delighted to say that we've got some remarkable and fantastic guest speakers joining us. So we've got Layla Hambeck from formerly known as AIM, but IPA, Independent Pharmacy Association. I think a lot of you are familiar with Layla already, and also Paul Rees, MBE and CEO for National Pharmacy Association. So we've got some really fantastic speakers, and I think as part of community pharmacy and our pharmacy workforce, it would be a shame if you missed out to hear what our speakers have to say, but also more importantly, it will just be on the brink of potentially the announcement of the new contractual pharmacy framework, or our pharmacy contract as well, because obviously we're waiting for news of the negotiations on that. So I hope it'll be really timely, but either way, I think it will be a great thing for you to hear from our guest speakers. And within that, I've mentioned our AGM theme will be survival instinct, and there is a link that's already been set up. And if you visit our website, you'll be able to locate that. But we are sending out reminders on a weekly basis now, and that will be ramped up. You'll notice between now and 24th of September. So please do save the date. It's an evening forum between 7:30 and 9:30 as well. And we will obviously give you the opportunity and invite you to ask questions to our expert panel as well, and that will be happening in the next couple of days, either from myself or Kate, our administrator, who's joining us tonight as well. One really important thing I wanted to raise and just quickly highlight, and do feel free to use the chat function or raise your hand if you have any comments or concerns around this, was around the GP collective action. And so hopefully you're all aware of what that means, but at the beginning of the month, the GPs across England began to take collective action following a ballot of partners within the BMA, and that means a number of GP practices have decided that they're going to be working to rule, and that means only undertaking tasks that are included in their NHS contract. Now, what does that mean for community pharmacy or GP practice alone? So it means that from a GP practice, it could mean that they're offering fewer GP appointments, And that in turn could have will result in more patients accessing community pharmacy for services and advice as well. So we're very mindful, and I've been working with the ICB very closely on this, monitoring this, and also other within the system, within the ICS as well. But very conscious that potentially this could have a massive impact onto community pharmacy. And bearing in mind we are already working under pressure, and have an immense workload as it is. So I'm really interested to know what actions your local GP practices are taking, and just as importantly, how that's affecting you in your pharmacy, in particular the work that you're doing. So we've set up a web form which you can access again via our website. I have added the link in my slides, but I'll also pop it in the chat function for you to access. And I'd be really interested if you could report any of these issues. One being unfunded work that you are having or your teams are having to undertake as a direct result of the GP's collective action. Second of all, if you need to go into business continuity measures that result in walking patients being signposted elsewhere. Thirdly, any influxes of referrals near to the close of business that means patients have to wait until the next day to, for example, receive a pharmacy first referral, and finally referrals outside of the normal types of work pharmacy are expected to deliver. Now, it's really important, and I know it's very difficult for some of us to identify that whether your normal activity, because you might be thinking, well, that happens already, Rajshri, and how do I know it's as a result of GP collective action, or it's already, or actually it's just been absorbed as the run of the mill and the ordinary day to day. It's really important that you have that conversation with your practice to understand whether they are participating in GP and they're undertaking GP collective action, and how you can support, but also allows you to make some preparation plans as well behind the scenes. So if any of those 4 scenarios resonate, please do complete that web form. And if you can't locate the web form, do get in touch with me, pick up the phone, whatever you need to do. I'll be happy to take the details over the phone or on a phone call as well. But it's very important that we are able to collate that feedback from you, so then we can report that back to ICB and start to work together with our ICB to put some mitigations, but also some solutions as well within that, and target that as well if there's specific localities that are affected more so than others as well. Moving on, gluten-free consultation. You've probably seen my reminders on a weekly basis, either from myself or Kate. But this is a proposal from ICB to stop gluten-free products being prescribed on FP10. And a number of systems have already gone down this route, and LLR hasn't. And this consultation is open. It's a public consultation, but means also allows feedback from community pharmacists and their teams as well. The deadline is this Sunday. Again, I've put the link in there, and if you go onto our website, it is on the main page for you to locate further information. I did have a chat with somebody from who's currently working on the consultation, and I have received the feedback that there has been there's been a low rate of feedback from community pharmacy. So if you are wanting to feedback, please do so. And the deadline is by Sunday, and that's this Sunday as well. It'd be really important, actually, as a sector, that we have our say as well. Otherwise, it will just be one of those things that potentially we lose, and then we talk about afterwards retrospectively. And now that we need to talk about it and make our views known, rather than talking about it retrospectively when it's too late. Okay, so this is the final consultation on that, just to make that incredibly clear. And that's it from me. That was a real whistle-stop tour. Before we go, let me just double check. Before we go to Dr. Sorry, did somebody say something? No. Before we go to Dr. Ashman, Ginny, is it okay if I just come to James before that, just to ask if you've got anything else to add, if that's all right?
Of course, yes.
Thanks, Ginny. James, can I just hand over to you? you know, just to give you the platform and the audience for the next 1 or 2 minutes. If you need a little bit longer, that's absolutely fine. But just to introduce
Yes.
yourself. Yeah, perfect.
Yeah,
I'm going to
yeah,
stop
that's
sharing.
absolutely fine. Yeah, no worries. Okay. So evening all. I nearly said morning because that's how I work, but there we go. Evening all. That makes me sound old school, doesn't it? Right. So my name's James, James Stevens. I'm the Controlled Drugs Liaison Officer for Leicestershire Police. A little bit about me. I don't know if you've seen the blurb that went out already. I've already seen the blurb because I'm a narcissist and I've looked it up. So it's very good, by the way. Picture's looking good. I like it. It's very good. Yeah, so I am the CDLO for Leicestershire and Rutland. I've been in the police for 22 years, done a lot of work regards to frontline stuff, public order, undercover stuff, and I've done a lot of offender management for the last 10 years, dealing with sex offenders, murderers, young people. This job came up, sounded really interesting, applied for it, and obviously here we are today. So I've been in this role since April 22nd, and it's a role I didn't even know existed, and it is a really, really interesting role, and the work that the pharmacies alone are doing is unbelievable. I am so impressed. So my role is basically to work with the CDAO, which at the moment is Amit Dowda, but Amit's going to move on to the West Midlands side, so I'll be working with Sam Travis. And a lot of my work is around the monitoring and controlling of Schedule 2 drugs mainly. So that involves me obviously visiting pharmacies and anywhere that's got controlled drugs. So you name it. I can't believe the amount of places that have got controlled drugs. So pharmacies is a bread and butter. Then you've got online pharmacies. Then you've got care homes, zoos, military bases, you name it. And I'm going to all of them. I am pretty confident by now I've visited all but bar 5, every single pharmacy in Leicester, Leicestershire and Rutland. I just wanted to go in there, visit people face to face, let them get to know me, hand over the business card, give them my contact details, because what I want to do is I want to give people a personal touch. I want to give people a chance to know what I do, have a quick chat with them, any concerns, have a look around the place, and we all make first impressions. They'll make one of me and I'll make one of the place I'm attending, and they're all really busy places and they do a really good job. So the biggest thing I'm looking for when I walk in is just the presentation of the pharmacies. What I'll do is I'll be checking the registers, whether it's online, whether it's a paper one, to make sure it's all balances, checking the cabinets. We had one last week I could pick up with one arm and walk away, so that's getting changed. So yeah, it's and then we'll do targeted inspections regards to if we receive information, if there's something somebody says to us where we need to have a look at somewhere, we will do it. But I see my role now. Everyone thinks police and they see my role as enforcer. I walk in there, do as I say, I'll arrest you. Not the case at all. I've worked with partners for years and years in the council, and I intend to go into somewhere, and if there's any issues, I want to work with these people in order to get everything up to code and up to standard. So I'm not about prosecuting. That's the absolute last thing I want to do. Now, I've recently had a case where we've had a patient that's abusing the Oromorph and is using it and then going out to the car park and dropping it, and then obviously having it filled up again and basically swindling the NHS out of this Class A drug. And we've had a sit down and spoke to this person, and at the moment we feel that it's stopped. So I'm all about putting the patient first. I'm all about speaking to people. And I just wanted to just come here today just to say I'm here to work with all of you guys. And if you have any issues at all, please let me know. And it can be anything in regards to drugs, or it could be that the shop has had a break-in, or it could be that people are concerned of ASB. Anything at all where these pharmacies are, if you've got any issues, obviously contact me. I'm your contact. If you say to me, my pharmacy has kids hanging around at 8 o'clock at night all the time, I'll have a word with a local officer. I'll get it sorted out for you. All these little things I can do other than just the pharmacy side of things, if that makes sense, or the day-to-day stuff. I can help out and do all of that for you. So I will put my email and I'll put my work mobile number in the chat in a second, so you've got that. But I just want to be as approachable as possible. There's no silly questions, and I just want to work with you guys, and whatever you need, I will assist. Whatever you need, whether it's intel, whether it's working with partners, whatever you need, I will do it. So if you have any questions, obviously, if you think of them later on, you can email me or you can ask me now. I really don't mind, but I'm an open book regards this, and I'm learning about this all the time. So I just appreciate having a few minutes today on this platform just to speak to yourself. So thank you.
Thanks, James. That's really great. And just thank you for the information as well, in terms of, it's not just controlled drugs that you're there to help community pharmacists for and their teams. It's issues, anything around pharmacy. So if anybody does have a question or any comments, feel free to pop your hand up or add it into the chat. And I'm sure James will hang around for the remainder, or if you need to get away, James, feel free that you have to.
No, I can hang around for a bit. That's fine.
Oh, lovely. That's great. But lovely to, for the guys to be able to put a face to the name and just hear you talk as well. So thanks for doing that. Really appreciate that.
No problem.
Right, moving on then. Ginny, can we come to you now, if that's okay?
Sure, yes, thank you very much. So firstly, thank you so much for inviting us to come back. We obviously didn't kill you off with our measles talk last time. So this time, again, it's another clinical update, really, just to get you abreast of the situation with whooping cough, pertussis. I'm just going to share some slides and talk through them. And please feel free to put questions in the chat or to stick your hand up. If I see your hand, I'll happily respond to it. But if not, we can maybe answer questions at the end. So pertussis and whooping cough, I'm sure you realise, are exactly the same thing. It causes a lot of confusion for the public. We're tending to call it whooping cough in brackets pertussis, but honestly, mix and match. So first of all, just looking at confirmed cases, the reason this is on our agenda, much like measles was, is that actually there's a real outbreak type situation going on in the UK at the moment. And when we look at the sort of cases, you can see on the left chart there, it shows you in all the different age groups how many cases we've had each year over the last few years. You can see 2012 was a bumper year, unfortunately, but thankfully not so bad for the tiny babies. But it's sort of niggled along, and then you can see COVID there really clearly when there was no transmission of respiratory diseases at all because everyone was locked down. But as you can see, the graph then starts to lift up quite rapidly. And to the right, on this particular chart, it's showing you the line graphs are each of the different years in recent history, but the histogram portion of this is this year. That's what's happening right now. And sadly, associated with this very strong uptick in pertussis cases, we have had 10 infant deaths so far this year. So really, really difficult and tragic situation. Now, the numbers for July, I'm told, continue to slightly settle or dip. However, UKHSA are not remotely convinced that this is the end of it, because we're all about to head back indoors, go back to school. Social lives are about to really change again going into the winter. And their fear is that we will see a distinct uptick in this data again very soon. If we look at the sort of actual cases in the East Midlands, so this is focusing on us rather than the whole of the UK, the greyed out zone at the end of that histogram is the uncertainty. Now, as I'm going to come on to in a moment, pertussis can be a very long illness. It isn't necessarily quick, and it means that we sometimes don't find out or confirm that something is pertussis for quite a few weeks. And this means that we can then retrospectively add cases to this chart, which is why there's such a huge time period of uncertainty at the end of it there. You can see from the little blue chart top left that the cases of pertussis that have been notified, and just like measles, this is a notifiable disease, so UKHSA must be notified of every one of them. The cases are very much predominating in the county rather than the city or even Rutland. I mean, we've had quite a few cases in Rutland proportionally, but the city is relatively quiet compared to the county. And there are lots of reasons put forward for this. The main one we think is that perhaps it's going undiagnosed more frequently in the city, that people aren't flagging it, they're not presenting to GPs, they're not finding out what it is. They're just sort of putting up with it, perhaps. And there's this concept of the black cough, which quite a few cultures have a name for a long-term cough, which we suspect often could be whooping cough, and they don't necessarily come forward and present for care. The other thing going on in the county is that it's a slightly older population group than in the city. And pertussis immunity, after you've had your vaccines and so forth, unlike measles, pertussis, it wanes. So it disappears gradually through life. So the older you are, the more likely you are to be vulnerable to catching pertussis. So that might slightly be the reason for the higher numbers in the county. When we look down at the bottom here, this green and orange chart is showing us what the vaccination uptake is like. Now, we'll come on to it, but the main point of concern for us is tiny babies. And that means that maternal antenatal vaccination is by far and away the most important of the various pertussis jabs that are offered. In fact, you get offered your first one through your mum's pregnancy, then you get offered 3 in young babyhood, and you get offered another one preschool. But this maternal one is the one that's most important to us, because this is the one that protects tiny infants from becoming seriously ill or even dying of pertussis. And you can see that, unfortunately, if you look at the LLR line there, we're only hitting 57% last year of pregnant mums having this jab. And perhaps we've seen a slight uplift, 59.3% in that's, I think that's supposed to be Q1 of 2024-25. Apologies, I don't think it's Q4. I don't think we're there yet. But you can see the numbers are not great. This vaccine is 92% effective. So the actual number of protected infants is actually slightly smaller than this percentage. So a really worrying picture, with almost half of our population in the city certainly vulnerable to it. So Bordetella pertussis is the name of the little beastie itself. It's a bacteria infection, and it's very infectious. So harking back to a similar slide from measles, if you look to the left, you'll see the COVID natural reproductive number. That is, if we put COVID into a naive population who had no immunity already, they wore no masks, they didn't socially distance, how many people on average would catch COVID? For COVID, the natural number is about 2.5, between 2 and 3. With pertussis, it's more like 12 or higher. So it's way, way more infectious, more similar to measles in terms of its infectiousness. And certainly, if you took a case of pertussis, for instance, in a household, so if you lived in a large family, there were 10 of you at home and one person brought pertussis home, if people aren't already immune, you can guarantee that pretty much 90% of the household will end up catching it from you. So very infectious. Just like measles, it's spread, and like COVID and so many others, spread by cough and sneeze droplets that you might breathe in through your nose and mouth, or you might touch them on surfaces where it can live for several hours, and then you might, rub your finger in your eye or in your mouth or in your nose, and the droplets can get in that way. Once the bacteria has got down into your lungs, it really invades into the little nooks and crannies of the lungs, and it releases a toxin. That toxin causes lung damage, and the lung damage causes sort of bogginess, really, swelling, wetness in the lungs that shouldn't be too wet a place. So there's a lot of sort of inflammation down in the soft tissues of the lungs. In terms of symptoms, on this one, I want you first of all just to swing your attention to the right. In little tiny babies, there's often not much warning about whooping cough. Often the first thing that happens is the baby will start grunting or actually have an apneic attack and just stop breathing completely or go blue. So it can be very dramatic in babies. They can just very quickly become overwhelmed with pertussis. But it's possible that, particularly if you're an older child or an adult, you might get the more classic symptoms. And that would involve, first of all, thinking that you've got a cold. So just like measles, really, you'll start off thinking, oh, I've caught a bad cold, runny nose, bit of coughing, just got the snots, not quite right, maybe a little bit of a fever, but nothing dramatic usually. But what it then builds up into is cases of prolonged, repeated, and sometimes quite violent coughing episodes, which we call paroxysms. So almost unstoppable episodes of coughing. And when you eventually manage to take a gasp of air in, you create this whooping noise, which is where whooping cough got its name from. People often become really exhausted by the paroxysms of coughing. So fatigue and exhaustion is common. And the other thing is that after all this coughing, in a coughing bout, you'll sometimes find that people will vomit. Now, what I want to do there is just stop off for a second to show you this little video, which is embedded as a link into the slide set, which will be shared with you later. So you can watch this for yourself. Hopefully you'll hear the sound. Please give me a thumbs up, Rajshri, if you can hear it.
Okay, it's okay. Okay, take a breath in, honey. Come on. Come on, there. There we go. Oh, it's okay. It's okay. Yeah, it's okay. It's okay. Yeah.
Oh, you can take a breath. But isn't that just dramatic? It just makes the point so strongly. So for children, older babies, children and adults, that's what you'd be experiencing, which is why you'd be so exhausted. But little tiny babies, even more vulnerable than that little baby, it can be worse than that. It can just be a sudden onset of apnea or blueness or inability to do anything much. Let me talk you through the time scale of it, because the time scale it can be very variable. So the top line here is somebody experiencing the quickest version of pertussis pretty much that you can experience, and the bottom line is the slowest version. And notice that the scale on this one, unlike the measles one, which was in days, this is in weeks. So the longest version is months of being unwell. So it really is dramatic. So this is the contact point at sort of the 0 point. This is when you might have picked up the infection. You then incubate your Bordetella pertussis for anywhere between 5 and 21 days. That's the yellow zone. You'll then get these sort of early stages of cough and cold type symptoms and get catarrhal and snotty and feel grotty for 1 to 2 weeks. But it then quickly develops into this paroxysmal coughing fits, these exhausting coughing fits with vomiting at the end of them. Now, those can last minimum 2 weeks, but often can go on for 6 weeks, which is just extraordinary. And you'll then find that you'll go into a convalescent phase, which is another 2 to 6 weeks of gradually getting better while still actually being worn out, coughing a lot, and generally feeling absolutely rubbish. In terms of infectiousness, in blue here, you can see that you're infectious from pretty much at the end of towards the end of the catarrhal stage, but about day 6 of your catarrhal symptoms, right through until 3 weeks after the onset of cough. So it can be very protracted and incredibly unpleasant. Some people, of course, will get a really mild version of pertussis. They won't even know that they had more than a cold. So of course it happens that some people get mild versions, particularly those with some residual immunity, perhaps from vaccination, so younger people especially, but it can be horrible. So the point about immunity waning, just to point out that when you have your primary vaccinations at 8 weeks, 12 weeks and 16 weeks, those are designed and Mother Nature has them working for around 5 to 6 years. So quite a long time, really protecting kids through those early years at school. But the preschool booster that you have then pushes that even further so that most of your junior school education, you're covered. So the kids that do get vaccinated in childhood are probably covered through until they go to senior school. But most adults and many teenagers are no longer immune because of waning vaccination immunity. Remember that the whoop noise is often absent in young infants. We've got a very low threshold for admitting children to hospital if we suspect pertussis and they're under 6 months of age. So if you did see a parent and you were suspicious, it's not one of those, oh, wait and see kind of things. It would be a, go and see your GP now kind of an issue. If you may have lots of patients who come into you with long-term cough, I've had a cough for 3 weeks, I've had a cough for 6 weeks. And of course, we've got a huge differential of things that we worry about with long-term cough. But just to add pertussis to your list of things in the back of your mind, and certainly be aware of this underreporting in some communities because they feel that the black cough is something which does eventually go away by itself. Antibiotics can be prescribed, but usually, pretty much always, they're only aimed at reducing transmission. So they're not usually given speedily enough for them to impact on the course of the disease for the individual having it. So it's more that if people are on antibiotics, they can get back out into society a bit quicker if they feel well enough to, because it reduces their infectiousness. And then the next thing, this is just a reminder about pertussis vaccination in case you get any inquiries about it. But maternal vaccination, ideally, it can be given somewhere between sort of the 20-week FASP scan, so the detailed scan that mums attend either Leicester General Hospital or Leicester Royal Infirmary Antenatal Clinic to have. So around that scan appointment is usually the time when it's offered. But if they miss that appointment for any reason or don't get jabbed, then they can have it any time up to 32 weeks of pregnancy for ideal effect. It takes 2 2 weeks or so for them to have a good immune response, and then a little bit of time to allow the babies to get the antibodies floating across the placenta into the baby's bloodstream to protect it. But if a mum has missed that 32-week opportunity, it's not a clear-cut deadline. She can have it any time up until she goes into labour, or even actually when she has a newborn baby to take home, she can still have it up until the baby is 8 weeks of age. And the reason for that is that the baby is not going to get offered its first jab for itself until it's 8 weeks old. And those 2 months are such an important, dangerous time in terms of pertussis that we would rather protect mum and therefore have a sort of protective cocoon effect on the baby, and perhaps maybe even be lucky enough to get a few antibodies across in the breast milk, than not give it to mum at all. So it's very flexible, anytime from 16 weeks of pregnancy up to 8 weeks postnatally, but ideally between about 20 and 32 weeks is the ideal time. As I've said, 3 vaccinations offered to newborn infants and then a booster again before you go off to school. We can catch up on these. So if a parent comes in and says, oh yeah, my child missed all of those, reassure them that they can still contact their GP, they can have catch up. It's just that we don't do catch up doses if the child has already reached the age of 10. They deem it to be too late to be of much use, because 10-year-old children with whooping cough generally fare much better. I'll skirt over that because we've covered that, I think. Just to say there are various different products. It would be weird and wonderful if we had pertussis in a sort of vaccination all by itself. We don't. It's always mixed with other things. So it's usually in with diphtheria and tetanus, but often it's in with Hib and Hep B, and sometimes it's in with polio as well. So there are different products, different horses for courses for horses, horses for courses, whatever you want to say. And obviously the healthcare provider offering it will know which one to give. But that's just another thing mums can get quite confused about, in that they realise afterwards they didn't just get given pertussis, they got given lots of other things. Again, this next one I think we've covered. Just interesting to note down the bottom there that there is significant difference between Leicester City and the county and Rutland, and differences in terms of the uptake in the different age groups. When we look at the 12-month age group, the 24-month age group, and the 5-year age group of uptake, we're looking at a totally different cohort of children. So the older kids actually are more of a worry to us. If you look at the 5-year-old ones, those children, I suppose, were toddlers around the time of COVID. They perhaps didn't get taken for their preschool boosters, so they're more likely to be out of date in a way than the younger ones are. But nonetheless, very rarely are we hitting our 95% target, at which point we might have some herd immunity in our communities. Safety-wise, very safe vaccine. We've had huge numbers of vaccinated pregnancies in various different studies, looking at all different kinds of outcomes, consistently showing us that this is a safe vaccine to use. In pertussis testing, if anybody ends up with symptoms of pertussis, nasal swabbing and some blood tests are often what's needed. If parents come in concerned about the request they've had from the UK Health Security Agency to get swabbed, please try and reassure them. It's a great thing to do for the rest of society to work out who's at risk and who's not. This next chart that Sam has put together for you, I think you might find really useful. So it covers all the different vaccines that we offer in pregnancy. So it's 4 things. So pertussis, COVID, flu, and also now RSV from September the 1st is coming in as well. And these links will take you to the relevant information and resources that you might find useful if patients of yours are asking questions and wanting further information. There's also various resources on the UK HSA website, so lots of leaflets that might be useful to have in the pharmacy. And also this leaflet, which actually annoys me a little bit because it's a very recent leaflet, only just come out. It obviously talks about rubella, but of course pregnant mums can't get vaccinated with the MMR because it's a live vaccine, so they have to think about that before the next pregnancy rather than in this one. It does cover flu and whooping cough, but it doesn't cover RSV, so it's already out of date before it's even hit the shelves really. But it is there in lots of different languages, so it does cover some really useful information, but it's perhaps not the be-all and end-all. Another thing to point out is that our roving healthcare units now have, as well as COVID and flu, once that starts up, they will also have on them MMR vaccines and the pertussis pregnancy vaccine, and they will have the RSV vaccine. And we're hoping to get the pertussis childhood vaccines on there as well. So these vehicles, open access walk-in clinics, and we don't mind which of those vaccines people need. Obviously, it changes seasonally. COVID and flu times, there'll be huge queues of people wanting their COVID jabs, but around the rest of the times of year, it's mainly mums wanting to catch up on MMRs and so forth. But these are some of the venues it's at, and we're really welcoming anybody to turn up for those. And I think that's everything from me. So thank you so much for listening to me. And if there's any questions, I'll be very happy to answer them.
Thank you, Ginny. That was brilliant. That was great, actually. Are there any questions or comments, or do you want, I'll just leave it, see if there's any hands up or any comments? And I didn't see any questions being raised in the chat either. I guess one of my comments would be, or a question actually, Ginny, would be around, in one of your first slides was just about the numbers in terms of uptake of vaccine year on year. And we saw that declining, didn't we, year on year as well. And what would be the reason for the decline year on year amongst pregnant women? That's quite unusual, isn't it? Because you think actually with more information being accessible and raising awareness that there would be an incline. What's leading to the drop?
We feel it's multifactorial. We've certainly, asked lots of mums their thoughts on this, and it feels as if in recent years, particularly since COVID, they've been bombarded with a lot of information about vaccination, but of course, a lot of it from unreliable sources, a lot of it very negative and unhelpful. So I think information overload and the emergence of a really strong vaccine hesitancy message caused perhaps or driven a bit further by COVID is one thing. But we had been seeing a decline before this. Year on year numbers were going down. And I think part of that could be complacency as well, to be honest with you, because to be honest, if we're talking about, who has seen children die of measles, who has seen children dying of whooping cough, you've really got to ask my mum's generation for those first-hand stories, haven't you? Because since I've been on the planet, these vaccines have been available. So I suspect part of it is, and as healthcare professionals as well, we just don't see much whooping cough. We don't see measles. It's not something that we necessarily have at the forefront of our minds. So yeah, I think a mixed bag, and I think we've got a huge job to do to reassure mums and turn this round. But of course, having an outbreak on our doorstep is very sobering. And I think I'm hoping that the little uptick in vaccination numbers that we've seen will continue to improve. We're also hoping, although there is a risk that bringing in the RSV antenatal vaccination will actually threaten pertussis uptake, that actually it'll cause another hoo-ha of panic about, oh gosh, a vaccine's safe in pregnancy and all the rest of it. But what we're hoping actually is that in some ways the second vaccination of RSV will consolidate pertussis. And we're hoping that by offering it in some community clinics and on the roving healthcare unit, that actually that might put uptake, increase it a little bit. But time will tell.
Kate, you've got your hand up. Do you want to come in?
I was just going to ask, Ginny, are we okay to, the dates you've got for your roving? Are we okay to share those on social media?
Yes, I mean we're widely sharing them, and yes, you are. Those are all dates that are confirmed. So it would take something very serious happening for one of those to not go ahead. So that
I already share the things that come up on Leicestershire NHS and Rutland, but just so I've already got them, so I can get it scheduled in our end. That would be really great.
No, that will be fantastic. Thank you. We would love pregnant mums especially to get to know that it's perfectly all right to turn up at those vehicles for antenatal vaccinations. We think that could be really helpful. But particularly we'll perhaps come another time if we're invited to talk about RSV vaccination. But the problem with that one is going to be it's later in pregnancy, and it's at a time in pregnancy when mums don't have a detailed scan at Leicester Royal Infirmary or Leicester General. They've no need to go back to the hospital, and yet the vast majority of the service on offer is going to be based at UHL. So I think the community clinics will be even more important. We'd love to establish it.
Brilliant, thank you.
Thanks, Kate. And I can't see any hands or comments at the minute, but just I know you've alluded to this as well, Ginny, in terms of what can community pharmacy do and where our role is when it comes to pertussis. But if we were to summarise that, what is the role for community pharmacists? So what should we be taking away from this other than the clinical aspects, etc. But what is it that we can do like now, like when we go back to our pharmacies tomorrow? What would you like us to take away from tonight?
So I think if you have space on your notice boards or in your windows, it would be great to put up some of the informational leaflets that are there as a resource. So particularly the sort of pertussis vaccination in pregnancy type leaflets, that would just be brilliant. You know, a pregnant lady in the shop, if you have a few minutes spare, which you probably never do, but if you did, it would be great to engage her in conversation and reassure her. You know, you're at the heart of your communities and you have a level of trust from your community that other healthcare providers probably don't have established in the same way. So you're definitely a really, really important sort of influence on pregnant mums, especially when they're thinking about vaccination. But I think also the message also would be thinking about those individuals who perhaps do have a bit of a cough that's going on a while, and signposting and whether actually you could be encouraging people to stop and think and consider pertussis and consider going to speak with their GP or getting any tests done that might be necessary. So I think those are the main things that I can think of. But yeah, Sam, is there anything else you can think of that we should be asking? Shelf wobblers.
Sorry, I was on mute. I was just, the only thing I would say is if you have any ideas of what we could do to reach out to particular groups of people, please do let us know. We do have a bit of money, and so we're more than happy to fund things that we feel that would reach particular groups of people or communities to encourage them to get the vaccinations that they need.
Thanks, Sam.
You're on mute, Bashri.
Sorry, thanks, Sam. Thanks, Jenny. Are there any other comments or questions from anybody with regards to what Dr. Ashman has presented this evening? Gareth, coming in. Thank you.
Hello. Could I just inquire, Dr. Ashman, thanks very much, by the way, that was really enlightening. Are these issues not comprehensively covered in the antenatal appointments?
Yeah, I mean, certainly, yes, it's on the list of things that midwives must cover at every appointment. But if you could see the list of things that midwives have to cover at every appointment, you begin to focus your mind and realize that actually it can probably only get a small amount of time because there's so many things that at the booking appointment that they do need to cover. But yes, every midwife should be mentioning vaccination and checking that mums have all the information they want about vaccination at every appointment that they have. But really we want to sort of just put the belt and braces on that. And one thing to bear in mind is that, you know, if someone might have been going to see their GP or coming to see you as their pharmacist for years and years, and then they're pregnant and suddenly they're going to see someone who's a stranger to them, who rattles through loads of overwhelming bits of information, and it's all exciting and new and scary. So actually, I think a lot of it sort of goes in one ear and out the other. And then when things come settling back down to earth, actually, they're still left with a lot of questions. And the more of us that feel able and empowered to answer their questions, the better. So yes, of course, it is covered, but I don't think there's ever enough time given to it. And that's just the nature of the NHS.
Thank you.
Thanks, Gareth, and thank you, Dr. Ashman, as well. So I can't see any more questions unless there is, and you know, feel free to add it in the chat. But I don't want to, you know, leave this as make this painful and extrapolate this if it's unnecessary to do that. Sorry, Gareth, have you got your hand up again?
I have, Dr. Ashman. You brought another thought to mind then in what you've just covered. Every midwife is covering the issue, you know, the information. But are they not actually offering a vaccination, not just information on it? Are these patients not getting booked in, and then it flips over, they're actually having to not turn up for vaccinations? So is that the issue? Are they not being booked in?
Yeah, so it's a confusing system, Gareth. it's such a shame, really, but years ago, midwives would have physically done the vaccinating, or in childhood, health visitors would have done the vaccinating. Those skills have disappeared from midwives and health visitors. Those are not things they're funded to do. They've not been things that have been on their list of jobs to do for a long, long time. So our community midwives don't do the vaccinations themselves. So when mums attend Leicester Royal Infirmary or Leicester General Hospital for their 20-week detailed scan, as they go through that clinic and come out of it, there is a vaccination room, and it's an open access room. If for any reason it's not functioning, there'll be a sign on the door telling them, sorry, the clinic's closed. These are the places you could consider trying to get your vaccine, or you can come back here another day. So it's just an open access, cross your fingers, hopefully it's open today, kind of a service. And that's where the mums would go to get vaccinated. So it is really difficult, because the midwives would love to have more time with them. They agree that it would be great if midwives were actually vaccinating, because there's nothing better, is there, than having the conversation and then striking while the iron's hot. As long as the mum has got all the information and is confident, you can go ahead. But of course, there is that bit of delay. So it might be that someone in the scan room says, oh, have you had your vaccine? Are you going to get it? And gives them some information. But they then wander past the room on the way out, and they're a bit busy, and so they decide not to go in. So we're trying to increase the number of opportunities. All of these antenatal scans can also be done in general practice. So on demand, if a mum sort of requested it opportunistically or on demand, a GP can give them. But the GPs aren't fundamentally the prime sort of contract. That's not who it's commissioned from. It's commissioned via UHL. So it's the hospital team who are responsible to deliver the service. So not quite how I would set the service up if it were up to me, but it's what we've got, and it's what's going on over most of the UK.
Thanks, Gareth, for asking, and thanks, Dr. Ashman, for answering that. I can't see any more questions or any hands raised. So I'm gonna, if that's okay, move on, if you don't mind. And I'm just conscious it's almost 9 o'clock as well. So just want to say a sincere thank you to Dr. Ashman, to Sam for joining us, but also for James, to James for also joining us as well, to introduce yourself this evening to our contractors. If there are any questions from any of our pharmacists or contractors, feel free to stay on. I'm going to be here. So if there's anything outside of what we've discussed that you'd like to raise with me or the team, then do feel free that you can do that. But if not, I shall say thank you and give you 8 minutes back from this webinar. And we shall see you next month at our open house surgery. So again, thank you, Dr. Ashman, thanks Sam as well, and thank you, James, for joining us this evening.
Thank you very much for having us. We really appreciate the invitation. Thank you.
Thank you.
Pleasure.
Yes, thank you.
Thanks,
Bye.
everyone. Bye-bye.